in the course, we will be talking about how does amniotic membrane work, how to prepare an amniotic membrane on your own, amniotic membrane transplantation in acute conditions covered by Dr. Tuhin Chaudhary, and amniotic membrane transplantation for ocular surface healing will be covered by Dr. Aditya Pradhan. I will be covering the mechanism and the preparation of the amniotic membrane. So the human amniotic membrane is a versatile toolkit in every cornea and ocular surface surgeon's arsenal. Coming to the history a little, first it was used by Davis in dermatology in 1910. First ophthalmic use was done by D. Roth in 1940. Sosby and Simmons used it for chemical injury in 1946, and it was popularized by Seng in the 90s, and it is used in a whole array of surface surgeries. Now, if you look at the PubMed searches from 1999 onwards, the number of publications and searches for amniotic membrane has gone up, owing to its versatile use in so many surgeries for cornea as well as ocular surface. Now, if you look at the basic anatomy, the cornea and the amniotic membrane look pretty similar. There's an epithelium with a basement membrane, there's stroma, again a basement membrane, and an inner cell layer. But here, when we see the epithelial layer with the basement membrane is there, the stromal extracellular matrix has a compact and fibroblast layer. Then we have a spongy layer and the chorion, and the thickness is 20 to 500 microns. The amniotic membrane is the translucent avascular innermost layer of the placenta. The epithelium have microvilli, and the basement membrane is made up of collagen 4, 7, fibronectin, laminin, hyaluronate. The stroma has 3 parts: the inner compact, middle fibroblast, and the outer almost acellular spongy layer. Now, what is the mechanism of action? It has a multifactorial therapeutic action. First of all, there is no immunogenicity because there is limited HLA expression on the surface. The membrane is translucent, so the patient can see something, and we also can see the clinical response. It provides mechanical support and moisture retention, and the basement membrane has similar collagen composition to the cornea. Human amniotic membrane has a tremendous collection of chemokines and cellular growth factors, which are preserved even after -80° storage. So it promotes epithelialization right from cell differentiation, cell adhesion, cellular growth factors are present, has anti-fibrotic properties, suppresses the TGF-beta expression, anti-inflammatory properties, inhibits interleukins, interferon gammas, FGF, TNFs, anti-angiogenic properties, has thrombospondin, endostatin, and tissue inhibitor of metalloproteinases. Antimicrobial properties, it acts like a mechanical barrier itself, and has batricidin, lysozyme, beta-lysine, and transferrin. So what are the types available? We have the freshly harvested, cryopreserved, lyophilized, or freeze-dried, which can be stored at room temperature. And we have the commercially available, which is attached, like Procara. And here is shown an Oro AM inserter, which is only an inserter, which has a double ring and interlocking mechanism in which the amniotic membrane can be placed and it can be closed, which also acts like a symbiophron ring, and the amniotic membrane is present. So the types of surgery that can be done with amniotic membrane, the inlay technique. Here it is cut to fill in a surface defect, like after excision of an OSSN or pterygium. Can be used as an onlay or overlay technique when we use it to cover an unhealthy surface, for example in chemical injuries or SJS, and filling in or layer technique where we use it to fill up a tissue loss like in perforations. Now looking at the preparation from the placenta, source is of the placenta from an uncomplicated C-section. Usually antenatal serology is already done, but the serology with the cord blood is again done to double check for HIV, HBsAg, HCV, and syphilis. COVID negative PCR is important in the current scenario, and the preparation is done on the same day as the procurement. The materials used, we have the Dalbecco modified Eagles medium, sodium bicarbonate, streptomycin, penicillin, amphotericin B as the antibiotics. RO water is required, glycerin, normal saline, nitrocellulose paper, and NaOH or HCl for the pH adjustment. Other materials like graduated flasks, beakers, cylinders, a filter and pump with sterilized tubing, filter paper, pH meter, weighing scale, sterile bottles and caps, and heat seal and labels are required. So first, after getting the placenta from the OT, the cord blood is taken for the serology. Then all the components are mixed and the pH is adjusted between 7.6 to 7.8, and here the pH meter is used and titration is done. After which this thick solution, which also contains glycerine, is put in a filter. We have Whatman filter paper, 2 or 3 which are put in between. And as this solution is quite thick, there is a suction pump with sterile tubing which helps to create a negative pressure and pulls the liquid down so that the filtration process can be smooth and quick. Now, anatomical suppression of the membrane is done from the placenta and washing of the placenta is done. At this point also antibiotics are added. Now the placenta and the amniotic membrane is separated. There is the epithelial side and the sticky stromal side. A nitrocellulose paper is taken and cut into small pieces. And then it is put on the stromal side where it sticks nicely. And now these pieces are cut. So initially we can take up bigger pieces which can be then subdivided according to the need. We can have 3 into 3 mm pieces also for larger ocular burns and where we require a bigger amniotic membrane, as well as the smaller ones. The medium is then filled into sterile containers. And then the amniotic membrane is put inside the container. And then all the containers are labeled with time and date. So the quality control and storage should also be done. Culture for blood agar and SDA needs to be done. These vials are stored at -80 degrees Celsius. Need to maintain a maintenance and distribution log and the freezer temperature log. So to conclude, AMT is an extremely versatile surgical technique for the cornea and ocular surface surgeon. General ophthalmologists should learn the basic use for ocular emergencies, especially in multidisciplinary setups. It has a wide array of indications and techniques which will be covered further, and making your own is not so difficult with a standard microbiology lab. Thank you for your